Hello, and welcome to our video targeting our paper entitled Nursing's Role in Psychosocial Health Management After a Stroke Event, a scientific statement from the American Heart and American Stroke Association. My name is Pat Zrelak. Currently, I'm the Regional Stroke Program Manager for Kaiser Permanente in Northern California, where I oversee our 21 stroke centers. Professionally, I'm a nurse and I'm also a PhD-trained epidemiologist. I am the chair of the writing committee.
Hello, I'm Karen Seagraves, Vice Chair of the Writing Committee, and I am a PhD-prepared nurse practitioner and clinical nurse specialist, and I've spent 25 years in the care of stroke patients.
We are so glad that you're joining us today and would like to thank the American Heart and American Stroke Association for commissioning this paper. We would also like to provide special recognition to the Cardiovascular and Stroke Nursing Council and the Council on Lifestyle and Cardiometabolic Health for their support in this work. Karen, would you like to provide an overview for the need for this statement?
We have made significant advances in clinical treatments for acute stroke, including thrombolytics and AI-guided intra-arterial therapy. But to date, quality metrics have focused on timeliness to treatment and reperfusion, with limited consideration for what happens after discharge from the hospital. Our national guidelines provide clear evidence for clinical management of stroke, but guidelines for management of psychosocial symptoms after the acute event are limited. For many years, I had the great honor of facilitating a stroke support group for survivors and their families, and it was evident that stroke survivors experienced symptoms that included anxiety, fatigue, stress, and depression that impacted their quality of life and their recovery. One survivor confided in me that her stroke occurred while she was asleep, and she awoke with symptoms, and therefore she had great anxiety over going to sleep at night. Many of these symptoms don't become evident until patients have returned home to resume their regular activities and integrate back into everyday life. Therefore, in collaboration with the CVSN Council, we affirm the need for this scientific statement.
Central to this paper is the main figure, which we are very excited to share. The figure highlights the 5 main psychosocial constructs covered in the paper. Depression, which is the most commonly recognized symptom, is first, and this is followed by stress, anxiety, and fatigue, and of course, this would not be complete without talking about quality of life. The figure significantly highlights the synergistic and multidimensional relationships between the different constructs, including the underlying biological and behavioral phenomena. Notably, the figure highlights the significance of structural and social determinants of health, which are so important, especially when we look at the impact of diversity, equity, and inclusion, as well as structural racism in stroke care. These are included in the outer circle of the model, and includes subjects such as the availability and quality of healthcare, environmental factors, genetic and biological embedding, signs and symptoms related to the stroke event, general health perceptions, functional status, patient characteristics, all of which impact quality of life, the next inner circle. For each of the symptom constructs, we address presentation, pathophysiology when known, screening, diagnosis, treatment domains, nursing care, and research gaps. A case study highlights the integration of these sections. In addition, Table 2 contains actionable nursing interventions applicable to all sections. This includes, but is not limited to, topics such as communication, medication management, nutrition, hydration, education, and interdisciplinary collaborations. Due to the under-recognition and diagnosis of the symptom constructs that we cover in the paper, one of the most important roles of nursing in the care of this patient population is the need for improved recognition and screening for the different aspects of psychosocial health. Table 3 contains a list of easily adaptable, validated screening tools for each of the covered constructs, along with the estimated time to complete each of the screens. Karen, can you further elaborate how you envision the scientific statement being used in the clinical setting?
Acute care rehabilitation and ambulatory nurses have limited guidance on screening for, measuring, or responding to psychosocial symptoms to promote psychosocial health in their patients. Opportunities for treatment may include pharmacologic, psychological, and psychosocial components, as well as referrals for social services, behavioral health, and education and financial resources. This scientific statement provides practical and actionable guidance for the frontline team to screen for and address psychosocial symptoms across the continuum of care. Nurses can use it to develop education for patients and families to recognize symptoms and provide guidance on obtaining resources to manage them, including when to seek professional care, as well as strategies to optimize quality of life. The theoretical model, case study, and table of validated instruments can be used to develop care plans across the continuum that promote a smooth and consistent transition of care, empowering nursing to promote psychosocial health and well-being in stroke survivors. We anticipate this will serve to augment the evidence-based clinical guidance that we use for medical management of stroke.
Finally, this paper highlights a call to action. From our review, we know that the vast majority of people that have suffered a stroke will experience at least one of the psychosocial constructs covered in this paper, and many will suffer from more than one. Of these, most will be underdiagnosed, and only a smaller number will receive appropriate treatment. So we urge you to evaluate your care and the care processes provided at your facilities across the care continuum using this paper as a guide. Moreover, this is an understudied area of nursing science. Extensive, innovative, high-impact nursing research is required. This spans from prevention to the creation of validated stroke-specific screening tools to the determination of the optimal timing and clinical setting for screening to appropriate interventions and treatment. Furthermore, we need to expand our study populations to include all stroke types from all settings, ranging from the hospital to intermediate facilities to community settings. We also need to be more inclusive of high-risk, underserved, and underrepresented populations. In conclusion, we would like to thank our interprofessional writing committee for their hard work and dedication. We hope that you will read the paper, implement some of the suggested interventions, and help propel research in this understudied but essential area of stroke care. On behalf of the writing committee, thank you for attending today, and we hope that you enjoy the paper.